This is Gene Hessel recording the podcast on physics of the anesthesia machine for tomorrow, Tuesday, April 14th. This is an outline of what I'm going to discuss, and these are some suggested reading for this. The first topic is resistance and type of flows. Resistance refers to a pressure drop as fluid moves through a tube. This pressure drop is to overcome the resistance. It is influenced by the flow rate and the type of flow. Typically, it's expressed in pressure drop per flow rate. Centimeters of water per liter per second. This illustrates measuring the pressure drop across a tube. There are two types of flow, laminar and turbulent. Laminar flow is smooth, orderly. The particles move in the same direction. Flow is fastest in the center and slower in the periphery, and follows Hessel law, in which the pressure drop is proportional to length, viscosity, and velocity divided by the radius to the fourth power. This diagram's laminar flow and the fact that pressure is related to flow and resistance. Notably, the pressure drop is directly proportional to flow. Turbulent flow, on the other hand, is disorderly. The flow lines are not particle parallel. The particles move in all directions, and the Hessel law does not apply. Instead, the pressure drop is influenced by the velocity squared, and inversely by the radius to the fifth power. This illustrates the difference between the two flows and the relationship between flow and the determining variables. Notably, the pressure is exponentially rises as flow increases because it's related to the flow squared. Turbulent flow can be either localized or generalized. These are examples of sites of localized turbulent flow. You can also have generalized turbulent flow, and this occurs when the velocity exceeds a critical level. This is estimated from the Reynolds formula given by this equation. This is expanded in this slide. When the Reynolds number is less than 2,000, flow is predominantly laminar, whereas when the Reynolds number is greater than 4,000, turbulent flow dominates. Flow through an orifice is also distinct and is given by this formula. Resistance in anesthesia circuits can be reflected by flow volume loops, which we can obtain on our modern anesthesia machines, or notably by a discrepancy between peak and plateau pressure. The peak pressure reflects compliance and resistance, while the plateau pressure reflects only compliance. Therefore, the difference reflects resistance. Normally, this is only 2 to 5 centimeters. In my opinion, this should be monitored in all patients, but it requires use of volume mode and have an inspiratory pause of 20%, which is standard on our most modern anesthesia machines. If the difference is greater than 5 centimeters of pressure, or certainly if it's greater than 10, there's a typo error here. You should rule out sites of obstruction, such as the endotracheal tube, the bronchospasm or secretions, or other sites. This shows a diagram of the pressure versus time, noting the difference between peak pressure and plateau pressure. Another way of assessing this is pressure volume loops, which reflects compliance, and flow volume loops, which reflect resistance. Some of the sources of resistance in turbulent flow in anesthesia circuits include the circle system, the breathing circuit, heat and moisture exchangers, and the endotracheal. The significance of increased resistance is that it increases the work of breathing if the patient is doing all of part of the breathing. The endotracheal tube is the usual source of resistance than the rest of the breathing circuit. There's lack of agreement at what level resistance is excessive. Anesthesiologists should be aware of how much resistance is caused by each component and use components that have the least resistance. These include minimizing the length of the conducting pathway, maximizing diameter, and avoiding sharp curves and sudden change in diameter. And beware of filters and HMEs. Another topic is rebreathing in dead space. Rebreathing refers to inhale previously expired gases. This may or may not include carbon dioxide. Of course, if you have a CO2 absorber in the system and properly functioning valves, there should be no rebreathing of CO2, but there may be rebreathing of other exhaled gases. The amount of rebreathing is influenced by the type of circuit and the function of the components, the fresh gas flow, and dead space. Dead space is divided into mechanical or apparatus within the breathing circuit and physiologic within the patient's respiratory system. Normally this is about 2 milliliters per kilo or about 150 cc's in the average adult. This includes the anatomic dead space in the conducting airways and the alveolar ventilated dead space due to alveoli that are not perfused. The consequences of rebreathing is it conserves heat and moisture, it decreases oxygen and anesthetic concentrations, and it may increase CO2. Let me next turn to the topic of humidity. Humidity refers to the amount of water vapor in gas. Absolute humidity is the mass per volume. Relative humidity is the amount versus the capacity when fully saturated. Saturated refers to the maximum water a gas can hold. At 22 degrees, this is about 19 milligrams per liter, and at 37 degrees, about 44 milligrams per liter. Vapor pressure is the partial pressure exerted by water. Medical gases are supplied as dry at room temperature. By the time they are delivered to the alveolus, they must be fully saturated with water and warmed to body temperature. Normally, the nose is the principal heat and moisture exchanger. By the time the inspired air gets to the trachea, it's about 30 to 32 degrees centigrade and about 89% saturated. Unfortunately, the endotracheal tube and supraglottic airways bypass the system. The effect of inhaling gases, dry gases, is uncertain. Probably it's greater in pediatrics, long duration procedures, and in patients at increased risk of pulmonary complications. Potential adverse effects include damage to the respiratory tract, heat loss, fluid loss, and endotracheal tube obstruction. How can we add humidity to the anesthesia circuit? I've listed on these various ways: CO2 absorbent, exhaled gases, low fresh gas flow, moisturing device, adding moisturing in breathing tubes and reservoir bags, use of coaxial tubings, and other systems. Heat and moisture exchangers are commonly used. They are sometimes called artificial nose. There are two main types: hydrophobic and hygroscopic. The advantage is they are cheap, easy, and effective humidifiers. They are also effective bacterial and viral filters. They avoid overheating and excess humidification. However, they have limitations. Temperature preservation is insignificant. They have limited humidification. They increase dead space. They have a risk of disconnection. They have an adverse effect on CO2 absorbers. They can become obstructed, and they may lose their filtering capacities. And they are contraindicated in the presence of thick, copious, or bloody secretions. This compares hygroscopic versus hydrophobic types of heat and moisture exchangers. Another approach is humidifiers. These may be heated, they are not used in anesthesia, or heated. The advantage is that they are more effective at humidification, but the disadvantage is their complexity, maintenance, and little benefits in terms of heat loss and complications. Therefore, they are rarely used in anesthesia circuits anymore, but they are usually present in ICU ventilation. These are some of the complications associated with heated humidifiers. The circle system is also a way of adding heat to the system. It allows a return of exhaled gases, which are already heated and humidified. The absorbent produces heat and humidification. And there is water generated by neutralization of CO2. After about 60 minutes at a fresh gas flow of 0.5 to 2 liters per minute, the humidity is about 50%, and it higher if you increase fresh gas flows, increase ventilation, and wet the. Let me then turn to the topic of heat. And I strongly recommend the chapter in the 8th edition of Miller's by Dr. Sessler. This may also be present in the 9th edition, but I haven't checked this out. In the past, 90% of patients post-anesthesia, either general or regional, will be hypothermic if nothing is done. The cause is a widening of the set point by the hypothalamus and reduced response and effectiveness to the hypothermia. The usual course of hypothermia during anesthesia during the first hour is a drop of 0.5 to 1.5 degrees centigrade. 2/3 of this is due to redistribution from the core to the periphery due to vasodilation and loss of defense mechanisms. Much of this may occur in the holding room before the patient arrives in the operating room. During the next few hours of anesthesia, there is a progressive but slower fall in temperature due to heat loss. Eventually, there is a level off or a valley when heat loss balanced by heat production. Heat loss during anesthesia is mostly from the skin. It's proportional to the temperature difference between the patient and the environment, proportional to the surface area of the exposed skin, and is more in pediatrics. The types of heat loss include radiation, convection, conduction, and evaporation. On this slide, I have summarized radiation, which accounts for about 70% of heat loss during anesthesia. It is electromagnetic energy transferred to the cooler objects in the environment, not in contact with the patient. Convection is transferred to air current. It is influenced by air temperature and amount of airflow and is reduced by covering the temperature. Conduction is transfer by direct contact to colder objects. It's proportional to temperature difference and conductivity of the object. It is increased by wetness. Closed prep solutions and irrigation solutions aggravate this. And evaporation is heat of vaporization. It occurs in the respiratory tract, open wounds, and exposed body surface. Other factors that influence heat loss include duration of exposure, site of surgery, IV fluids, and in higher risk patients, extremes of age, cachexia, females, and low BMI. The consequences of hypothermia include shivering, which has multiple adverse effects, abnormal metabolism of drugs, and metabolic effects. It also includes increased length of stay in the POR and PACU, cardiovascular complications, increased risk of bleeding, infection, interference with monitoring, difficult venous cannulation, and increased cost of care. What are some of the warming devices and strategy? The most important nowadays is forced air warming, the so-called bear hugger. Air-freed conductive fabric warming blankets like the hot dog. Liquid circulating devices. Resistive heating devices. Passive covering. Radiation heaters. Heat and humidification of inspired gases, and heat and moisture exchangers, which we've already discussed. Other strategies include use of low fresh gas flows, fluid warming, negative pressure warming devices, hot water containers, increased temperature of the room, esophageal warming devices, endovascular warming devices, and lavage warm fluids. Let's move on to some other topics. First, the gas laws. I strongly recommend this chapter in the MGH textbook. Remember, standard temperature of pressure is temperature of 0 degrees and pressure of 760 millimeters of mercury. On this slide, I've summarized some of the gas laws. The most important are Char's law, which says that at constant temperature, the volume is proportional to temperature, and Gay-Lussac's, which says at constant volume, the pressure is proportional to absolute temperature. There are other laws that you may wish to remember. Other laws are Graham's, Avogadro, and molar volume. Partial pressure is the pressure exerted by a particular gas in a mixture of gas. When only one gas is present, the pressure is the barometric pressure. When there is a mixture, the pressure equals the sum of the partial pressure of each of the gases. This is given by the percent of each gas times the total pressure. Again, this is Dalton's law, which says the total pressure is the sum of the partial pressures. To calculate the partial pressure, you get the barometric pressure times the partial pressure of the gas. Times the concentration of the gas expressed as a fraction. For room air, it's 20% oxygen. PO2 is 760. So the partial pressure is 760 times 0.21, or 160. If the expired desk flame is 6%, the partial pressure in the alveolus is 760 times 0.06 or 47 millimeters of mercury. To calculate the concentration is given by this formula. This illustrates the partial pressure of various gases in room air. Room air is 78% nitrogen, and therefore the partial pressure of nitrogen is 850. For air, it's about 160. For water, it's 10. For argon, it's 7. For CO2, 0.3. For a total of 760. Let's next turn to flow meters. They're used to measure the gas flow into the circuit and for measuring the tidal and minute ventilation into the pipe. Flow meters are used to measure the gas flow into the circuit. In the old days, these were measured by flow tubes. Nowadays, they're done electronically, and I won't discuss this, the latter. Gas flow tube meters are also called variable orifice area flow tubes or Thorpe tubes. They are mounted vertically. They are tapered. They become wider as they move upwards. They have two types of floats, bobbins and balls. For bobbins, you read the flow rate at the top. For balls, in the middle. They are specific for each particular gas. Notably, they are at risk for damage and leaks resulting in the low pressure It employs the concept of constant pressure. The pressure gradient of gas flowing around the tube exactly balances the weight of the flow. As the flow in the tube increases, the velocity increases, as does the gradient, causes the float to rise. Since the lumen of the tube gradually increases, the velocity and hence the gradient will progressively fall until it stables. The flow is then proportional to how high the float rises. These are illustrated in these two diagrams. Other flow meters are used to measure tidal and minute ventilation in the paper. Several different types are available. They are also used not only to measure flow, but also volume. They do this by integrating flow over time and creating the area of the flow time group. Let me then turn to vaporizers. Volatile anesthetics are liquid at room temperature. At equilibrium, there is always some vapor in the atmosphere above the liquid. The amount is dependent on the vapor pressure, which is determined by the agent and the temperature. Concentration equals vapor pressure divided by total barometric pressure. For isoflurane, the vapor pressure is 238, and so the concentration in the vapor chamber is 31%. For sevoflurane, it's 21%. For desflurane, it's 87%. There are several types of vaporizers. The conventional vaporizers, which are used for isoflurane and sevoflurane. The desflurane vaporizer, which is used only for desflurane, and the Datex Homeda cassette vaporizer, which is used for all types of agents. For further details about vaporizers, rather than take time today, I recommend you review this in standard textbooks. There are a number of hazards associated with vaporizers. This includes misfilling, tipping, overfilling, underfilling, leaks, and pumping effects. Theoretically, temperature influences function of vaporizers, but modern vaporizers are temperature compensated, so except for exceptional ranges in atmospheric temperature, it should not make a difference. Again, modern vaporizers are independent of fresh gas flows between 1/4 of a liter and 10 liters a minute. They are slightly influenced by the carrier gas, especially when nitric oxide is used. Pumping effect relates to the effect of positive pressure ventilation, but this does not seem to influence modern vaporizers. Tilting can influence this, and filling with the wrong agent. If you put an agent with a higher vapor pressure in a vaporizer designed for an agent with a lower vaporizer, you'll get a false high concentration, and vice versa. Altitude also affects the function of vaporizers. With desk-frame vaporizers, if the dial is set at 6%, it will deliver the same concentration, but the partial pressure will be lower than the MAC equivalent. On the other hand, with other tape vaporizers, the output is a constant partial pressure. So although the fracture will be elevated at higher altitude, the MAC will be the same. Let me next turn to anesthesia vaporizers. On this slide, I have summarized classifications: the type of reservoir, the power source, the drive mechanism, the modes of ventilating, and the issue of bellows. Bellow ventilators are sometimes called double circuit. They are pneumatically driven. It has a bellow in a box. The bellow serves as a reservoir for the patient's breathing gas. The bellows is squeezed by a pressurized gas delivered outside the bellows inside the box. The delivery of pressurized gas which drives is under electronic control. The bellow refills passively during patient exhalation. Once filled, excess gas is ventilated to the scavenger system. There are a number of problems. These include leaks, problem with the ventilator release valve, and electronic failure, and finally problems with descending ventilators, bellows, which I'll discuss in a moment. Bellows are classified as descending or ascending. This refers to the direction the bellows moves during exhalation. Descending bellows are attached to the top of the box and are weighted and fall during exhalation. Ascending bellows are attached to the bottom of the box and rise during exhalation. Older and some newer ventilators, anesthesia machines, use descending bellows, but most contemporary machines use ascending bellows, which are considered safer. Ascending bellows are considered safer in that they will not refill if experience total disconnect, will only partially fill if the circuit exceeds fresh gas flow, and will not entrain ambient air. On the other hand, descending bellows will refill with total disconnect, and if the patient has a partial leak, will entrain ambient air and thus dilute. The same is true if it develops leak in the bellows. Partial and volume alarms can be fooled. Another type of ventilator is the piston drive ventilator. A motor, electronic or otherwise, drives a piston back and forth, which determines the volume of tidal volume. On this slide summarizes the advantage of piston ventilators. They don't consume gas to drive, and they are very accurate in tidal volume delivery. But they're usually hidden and you can't visually observe them. They are relatively silent, and they can fill even with total disconnect and entrain room air if there's a circuit leak. This compares bellows ventilators with piston ventilators. A final ventilator which is used in our modern current anesthesia machines is a Draeger turbo ventilator called the TurboVent 2. It is electronically controlled turbine ventilator. I don't understand exactly how it works and how it is controlled. This is a diagram. It basically has a fan motor, like a hair dryer, and it shoves gas in, which is controlled electronically. This electronic control controls how fast it turns, the pattern at which it turns, when it starts, and when it ends. A third type, which we don't use, is the volume reflector ventilator, which is described in these next two slides, but is not relevant. A final point is the effect of changing fresh gas flow on tidal volume the patient receives. With older anesthesia ventilators, the tidal volume delivered by the ventilator was fixed. During inspiration, the expiratory valve was closed, and thus the tidal volume delivered to the patient consisted of that from the ventilator plus that from the fresh gas flow. Thus, changing fresh gas flow would change tidal volume delivered to the ventilators. Fortunately, newer ventilators have ways to avoid this phenomenon, which we will next describe. They do this in two ways. One is to monitor the exhaled volume and adjust the volume delivered by the ventilator to match the set volume. The second method is decoupling. Finally, even though the monitor adjusts the tidal volume delivered to match, it doesn't take into account changes due to compliance of the circuit. A second method used to avoid this problem is decoupling. What this system does is to divert fresh gas flow from the circuit during inhalation. This was used on the Narcomed system as diagrammed on this and the next slide. Latest monoventilators have adjustable inspiratory pressure limits. Some are user selected. If too low, you'll lose tidal volume. If too high, they are not helpful. Some have a preset maximum, typically 70 centimeters. The final topic is manual resuscitators. I recommend the thorough discussion of this in the Dorsch and Dorsch textbook. They are also called bag ventilators, manual resuscitators, self-inflating bags, commonly referred to as AMBU, etc. One must consider the components, the self-inflating bag, the inlet valve, the non-rebreathing bag, etc. They also have a number of optional components. This is also thoroughly described in the chapter in the MGH textbook on anesthetic equipment. They may be used during spontaneously or supported ventilation, and they have two parts: a self-refilling bag, non-rebreathing valves, and an oxygen inlet and oxygen reservoir. These are the three parts, and these are diagrammed in this diagram from the NMGH textbook. Unfortunately, they may be unpredictable and variable in terms of tidal volume delivered, in-stray volume delivered, the amount of rebreathing, and the resistance to inspiration, both during spontaneous and during expiration. Therefore, it's important for you to review the manual for each device.